Good day. My name is Dr. Meti. I'm a urologist, and today I want to talk about testicular torsion. And this is a condition where whereby the testis twists on its blood supply. What that means is that it will impede venous drainage, cut out arterial input to the testis, and without spontaneous detorsion or surgical intervention can lead to ischemic necrosis of the testis and testicular loss. Commonly, it's unilateral but can occur on both sides. That's an uncommon presentation. It's important to know this because of the risk of misdiagnosis of testicular torsion. It has occurred several times. I've experienced it on patients who have had testicular torsion misdiagnosed and hence mismanaged with very disastrous consequences for fertility as well as normal growth. So I've defined testicular torsion. How common is it? It's about 1 in 4,000 males, and usually it occurs in males under 25 years. There are two main types: intravaginal, extravaginal. You don't need to worry about these terms. This is urology for everybody. But intravaginal torsion usually occurs in children, whilst the extravaginal occurs in adolescents. So it's commonly a problem for children and adolescents, with a peak incidence between 15 to 19 years. So briefly, the testis is supplied by blood vessels, namely the testicular artery, which takes its source from the abdominal aorta. Then it is drained by a network of veins called the pampiniform plexus of veins. Now, during torsion, which simply means the testis twists on its vascular axis, this can lead to engorgement with the veins, so venous output or drainage is impaired. And then finally, arterial input is also cut off. So that is simply the testicular torsion. The risk factors, common risk factor is what we call the bell clapper deformity. This occurs when the tissue that is supposed to anchor the testis to the base of the scrotum is deficient, and usually it's a bilateral problem. So the patient is born with that predisposition. So the risk is somewhat equal in both testes. So if it occurs in one hemiscrotum and there is torsion of the testis, give it time. And from practice, 3 months, 4 months down the line, it can lead to torsion. Torsion can occur in the other apparently normal testis, and that can lead to the patient reaching testosterone levels, reaching castrate levels, because as soon as the testicular torsion occurs and there is no intervention, and the testis does also not go through spontaneous detorsion, it can lead to auto castration, so to speak. And this can lead to drastic reductions in serum testosterone, because we know that more than 90% of circulating androgens is from the testis. So if torsion occurs in one testis and that later on it occurs in the other testis, it can lead to the patient achieving castrate levels of testosterone. So that patient will go on to need some form of androgen replacement therapy in order to live a normal life. And if this occurs before puberty, then of course, the normal adolescent growth spurt, which is driven by androgens will also be affected. And then later on, the chances of the patients going through normal reproduction is also largely affected because the tissues that are responsible for production of sperm are also very sensitive to ischemia. And so the ischemic damage that results can damage or reduce the chances of the patient producing normal spermatozoa. So how do they present? Patients who suffer testicular torsion. Usually, they present with a sudden onset of severe scrotal pain. So testicular torsion is one of the differentials for acute scrotum. This may be provoked by exercise. Sometimes it occurs spontaneously in the child's sleep. And the child or the victim will usually alert the parents, who would then rush him to the hospital. There are other visceral symptoms such as nausea and vomiting, and this can be quite severe. And it's the pain is scrotal in origin, and so at presentation, even slight, gentle examination of the testis will provoke pain. There are clinical markers or tips that can help the attending clinician to pick testicular torsion. One of the observations is that the affected testis gets drawn up. The torsion of the testis on its vessels leads to shortening of the vessels, and so the testis gets drawn up compared to the contralateral normal testis. And usually, one of the signs, which is not all the time reliable, that can be used to distinguish between torsion and epididymal orchitis is what we call the Prenn sign. Epididymal orchitis is an inflammatory process, and so elevation of the testis, the affected testis, will cause some relief of pain. But testicular torsion is not an inflammatory process. And further elevation of the affected testis will not lead to any relief in symptoms. So again, whereas elevation of the testis in an inflammatory process like epididymal orchitis will lead to relief of symptoms, doing so for torsion will not lead to elevation of the symptoms. But patient might be so uncomfortable to even give you any clue as to whether there is any relief of symptoms or not. And usually they will present with engorgement and swelling, edema of the affected testis. So that sign might not be too reliable. And so that is why usually in the clinical setting, when in doubt, it's always important to do immediate scrotal exploration and not wait for elaborate investigations that we will discuss later. There is one clinical sign called the blue dot sign, and this blue dot sign is usually positive in fair-skinned people, like say Caucasians or white people, and it happens when the appendix testis. This is a rudimentary structure within the on the testis. When it gets twisted, it will present as a blue dot sign. So if you examine the testis, it will appear as a blue dot at the cranial part of the testis. But again, in dark-skinned people like Africans, this might not be a reliable sign to look for. And so whether you are sure or not, it's better to err on the side of better judgment. It's better to apply better judgment and explore rather than to err by waiting for prolonged investigations, which might lead to testicular loss. How do we treat? But that being said, most often a Doppler ultrasound, if it's readily available, can be ordered, and it will reveal a reduced intratesticular blood flow or absent intratesticular blood flow. In the absent cases, it means that blood supply to the testis is severely compromised. But again, most often than not, because these patients may present at any time of the day and the sonographer might have closed, or the Doppler ultrasound might not be available, or that service might not be within your jurisdiction, it's best not to waste time and rather focus on scrotal exploration when in doubt. It will come to how you can, oh, lights out.